Good evening, everyone. I'm Dr. Marty Ross, and this is another Conversations with Marty Ross MD tonight. I'm visiting with you from Seattle. As many of you know, I've moved back here again and opened up my practice tonight. I'm visiting with you from my home. I've got one technical problem that may interfere with how things go tonight, and that is my battery is low on my computer, and I forgot to bring my charger home from work today. But anyhow, we'll see how long we can go. I think we can get at least an hour out of this. We'll see. All right. For those of you that are coming back again, I'm glad to see you're here again. And I think that means you're probably getting some benefit out of this. For those of you that are new, welcome. And for all of you, there's two ways you could participate. Number one, you can write a question to me through the chat box function. It's usually I think it's on the right-hand side of the screen at the bottom, the way it shows up on your computer. And you write your question to me, and I'll try to give a response. Be aware, I get more questions usually than I can handle any night, and I'm not trying to avoid you if I don't get to your question. Okay, sometimes people write me and say, "Are you avoiding me?" And I'm not. I just get to what we can get to. Okay. The second way to participate is to see what questions other people have and see the responses I give to that. There's always some good learning that takes place out of that as well too. So I am creating a recording of tonight's webinar as usual. And if it all goes as planned, sometimes those recordings don't work out, but 99% of the time it does. And if it goes as planned, I will edit it up later this evening or tomorrow morning once I get my charger that I told you about. And we'll try to get it out to you tomorrow morning somewhere probably before 10 a.m. Seattle time, okay? Now, when I send it out tomorrow, it'll include a summary of what we talked about. If you choose to watch the video on YouTube, you actually can do timestamp. I have timestamps on there. You can skip to the various parts that you want to skip to as well, too. Okay. This is the last webinar for 2025, and I'm glad to be spending it all with you. Next week we will be off for the holidays. I think we'll probably be off 2 weeks. Actually, I don't think I'll be doing this on New Year. I believe that will be New Year's Day. I don't think we'll be doing it. When is the first? Is the first next Thursday or 2 Thursdays from now? Let's take a look here. I don't think we're doing it on the first because I don't think I expect many people to be here. Yeah, it'll be a Thursday. So I'm not going to be doing it on New Year's Day either. So we're off for 2 weeks now. This is the last one, and then we'll be off for 2 weeks. So in the second week of January, I'll be back with you again. In tomorrow's email, I will have a link that you can sign up for the January series when we resume that again too. Okay? All right. So without any further ado, let's go ahead and get started here. And again, my intention is to spend as much time with you as I can, as long as my battery holds out on my computer, which I don't know how long that's going to go here. I apologize for not bringing that charger home earlier. All right, let's see here. All right, first question is from Lori. Hi, Lori. Lori says, I'm very grateful for this time. You're welcome. Let's see, I was on the call last week as well. The support group at Generation Lyme are singing your praises, and this is making me want to set up an educational call with you and my doctor here in Savannah, Georgia. In order to get the most out of the call with you, what do you recommend to focus on for the first call? Thank you again, Lori. So Lori, if you want me to focus on mostly what's happening with you, I would book one of my 90-minute calls. And you'd be surprised at what I can get through in 90 minutes, okay? I could come up with a pretty good plan for you to do. The things I would need in advance when you do book a visit with me, there's forms I have you fill out that give me a lot of useful information. One of them is a yeast screening questionnaire. Another one is your health history. In addition, I would ask that you send me, when you send those forms to us, relevant labs that I can take a look at and any relevant history that you want me to have that would not be addressed within there, okay? And so I write up a doctor's visit note, which is basically a chart note, a medical record chart note. And then at the end of the visit, I send that to you, and that gives you information that you can share with your providers as well too. So if you're wanting a full view, pretty comprehensive view, schedule one of my 90-minute educational visits, and that will probably take care of you just fine. Okay. So for those of you that aren't aware, there's 2 ways you can see me now, and so I'm going to do a screen sharing to show you how to do that. Okay, so this is my practice website. It's martyrossmd.com. Okay. My practice is Marty Ross MD Healing Arts. And to make an appointment or to find out about the appointment options you have, you would just go ahead and hit this drop down menu here and then hit the Learn and Book Now. All right. And down here, I describe, here's the button you would push to book the appointment, but I encourage you to read about the two types of visits I offer. I offer an educational medical consult service, and I also offer a full medical service. Educational medical consult means that I can give you ideas and your physician ideas, but because I don't get to examine you and because I haven't seen you in person, I can only give you presumptive ideas. All right. So I can't do formal diagnosis, although I can tell you what I think is going on. I don't prescribe. I don't test. I can give you ideas of supplements you can do and lifestyle changes you can do. But again, it's considered to be more informational. All right. The way to get full service, which means I prescribe, diagnose, order, test, is to come out here and see me at least one time, and then I can prescribe and diagnose. For Washington State residents on a follow-up medical service, I can do telemedicine for them. For out-of-state residents, if you want me to be your prescriber, diagnoser, test orderer, you would need to come and see me in person each time. And I wish it wasn't that way, but that's what the law says. The law says that I can only do telemedicine for people in the state where they're located if I'm licensed there. And I'm only licensed in Washington State at this point, although I've got a New York State application pending too. So anyhow, so read through here. You're going to see the differences in what these visits are, how much a visit costs, etc. And if it is something that appeals to you, go ahead, click that Book Now button, and I'd be glad to help you. Okay? All right. Let's see here. All right, there you go. All right, Lori, thanks for the question. I look forward to helping you. I hope you do make an appointment. All right. Hello, Bill. Let's see here. Bill says, hello, Dr. Ross. I'm currently being treated for a long-standing Babesia-Bartonella infection. I did clarithromycin, primaquine, biodisrupt, lumbar kinase, methylene blue for 4 months, and then retested. I am still testing positive on TLab fish. Atovaquone 10 milliliter twice a day. Rifampin 300 milligram BID was added 3 weeks ago. This past week, I've developed severe neuropathy in my feet. I wake up at night with my feet on fire and have a hard time getting back to sleep. It is still there during the day, but not as severe. Do you think this could be a side effect of one of the drugs or a combination of the drugs? Or am I getting a Herx reaction? I also just went through an influenza type A infection and took a few naproxens for relief of symptoms. Your thoughts? Thanks, and enjoy your time off during the holidays. Thanks, Bill. Bill, I'm sorry to hear you're still testing positive. So everyone, Bill had a test done through, I assume had a lab test done through, or you wrote TLab. TLab is a newer lab system run by physician Dr. Bob Mosignani that is doing microscope exams using a genetic marker that gets stuck on the germ and it fluoresces so you can see it. Okay. And so on that type of a test, if the germ is seen, it means the germ is still in you. Okay. All right. And so Bill obviously has some evidence of that. All right. Now, Bill, as I look, I'm just looking back at what else you're on. So clarithromycin, primaquine, biodisrupt, lumbar kinase, methylene blue, and then you added in atovaquone and rifampin. So I need to look up one thing about rifampin here real quick, Bill, just a minute. I don't think of rifampin as giving neuropathy, but I want to double check from the side effect list here. No. Okay. So, and I haven't seen anyone develop neuropathy on rifampin before either. All right. So I want to be clear about that. What I wonder is, could it be from the Atovaquone? So Atovaquone is an antimalarial medicine, everyone, and it's extremely fat soluble. And sometimes it is so fat soluble that it becomes an irritant to the nerves in the brain, and sometimes maybe even out peripherally too, although it's rare that I see that happen. So Bill, I wonder, I have no way of proving, but I wonder if this is coming from your addition of the Atovaquone. The problem is, because it's so fat soluble, it could take a good month or so to get out of your nerve tissues as well too. It is also possible, you raise the issue of influenza A, and yeah, I mean, it could have some type of a post-viral type syndrome here as well too. I'm trying to see how long we're doing this now. So you added the Atovaquone, yeah. See, that time frame of added Atovaquone and then 3 weeks later started getting symptoms could be that the Atovaquone finally built up enough concentration. I would entertain, if I was still managing you or talk with your physicians about this, of possibly pulling off the Atovaquone. Your issue is going to be, it still may take about 3 weeks to 4 weeks for the issue to resolve. Now, when it comes to things that concentrate in fatty tissues, one of the ways to get them out is to heat your body up, because the act of heating will mobilize, take things that are fat soluble and move them into the bloodstream so they can be detoxed out of you more. So if you could tolerate it, you might want to look at adding in either a daily hot bath or doing infrared saunas or saunas in general. Now, keep in mind, if you do a sauna, you're going to get dilation to your blood vessels, and you may get better perfusion of the antibiotics through your system, and you may get Herxheimer reactions then. So you got to kind of balance that out, okay? All right. And then if I wouldn't add anything yet until you know what happens by pulling off the Atovaquone, okay? Because I wouldn't be trying to put another antimalarial in you and then still wondering if things don't get better, is this because the next antimalarial that was added in, basically. Okay? All right. One other thing that I need to look at, I believe, so rifampin and Atovaquone have a drug interaction, and I believe having rifampin on board bumps up your blood levels of Atovaquone. So it could be why you got in trouble, and I'm going to just quickly double check that. I wish I knew all these things off the top of my head, but I feel better checking at it sometimes too. Oh, go away. Okay, get that going. Let's see, get rid of that, get rid of that. So Atovaquone. All right, let's see. Oh, well, I was wrong about that. The combination may increase rifampin levels and decrease Atovaquone levels. So it would not be from an interaction between those. In other words, the Atovaquone effect that I'm wondering about would not be from rifampin increasing the Atovaquone, okay? But again, in situations like this, I would pull out the Atovaquone, wait a few weeks, and try to do some heating yourself to see if you can mobilize those out of the tissues better, okay? All right. Good luck to you, Bill. Sorry to hear about that. Hello, Nick. Let's see. Hi, Dr. Ross. Thank you for the help you provide us. You're welcome. What are your thoughts on using or adding DMSO to our treatment protocols for the 3Bs? Thank you for all you do. I don't really have a thought. I know I'm going to have to see. I suspect, because I'm beginning to get questions periodically about DMSO, if this has become something in the chat rooms, basically. So DMSO, if you put it in creams, can help get things to penetrate more deeply into the tissue if it's part of the cream. But I haven't seen anything that I'm aware of about DMSO improving antimicrobial treatments or anything like that. So I'm not familiar with what's going on in the Lyme forums right now and why somebody is proposing DMSO, although I am hearing it out there. So I have to look into it a little bit more and find out why people are proposing it and see if I can find any science behind it. Okay? All right. Good luck to you, Nick. Hello, Gary. Let's see. Would you consider below results hypothyroidism? The thyroid peroxidase antibody is 0.3, T4 free is 0.8, TSH is 3.38. Excuse me, everyone. I'm sorry. Here, I'm going to just mute you for a minute so I can cough and it's not hurting everyone's ears. Let's see here. There we go. All right, I'm back again. So I was in Vegas last weekend at a medical conference, and evidently what goes on in Vegas does not stay in Vegas, because I brought back something that I've been getting over the last 2 days. It's a lot better, but I may cough periodically during the webinar tonight, so I apologize for that. Anyhow, if we look at your blood studies, so TSH, everyone, is thyroid stimulating hormone. It's a chemical made by your brain, the hypothalamus pituitary complex. And it's made by the brain based on the brain's interpretation as to whether you have enough thyroid hormone in you, okay? So essentially, if the brain doesn't think there's enough thyroid hormone in you, it will make higher levels of TSH, okay? So high TSH often means low thyroid, okay? All right, I know that may be confusing, but a high number, high thyroid stimulating hormone, means the brain is screaming at your thyroid saying, make more, make more. And that suggests that there is low thyroid going on, okay? All right, now, if we look at what standard labs report as a normal TSH range, it's usually going to be somewhere like around 0.8 up to a 4.5 or 5. That's what a standard lab will say, okay? And the way that those standards are developed, when we come up with a normal test, it's based on the range that 95% of healthy people in the population fall into, okay? All right, I got a cough again. Hold on, everybody. Well, I hope that's the last one, but we'll see. I've got postnasal drip going down. That's what's happening back there. But anyhow, so 95% of people that are supposedly healthy have a TSH that will fall between 0.8 and 5, okay? At least that's what some labs believe. There's been further studies done of people in the healthy group, and if we take samples of healthy people and we do ultrasounds of their thyroid, we will find in a portion of those healthy people that they actually have swollen thyroids, meaning they have thyroid disease already, even though they feel good, okay? So if we remove those people that have swollen thyroids that feel good, then a normal range for TSH for 95% of those people falls down to 0.8 to 2.5, okay? So in the way I interpret thyroid is if a TSH is above 2.5, that means you have low thyroid, all right? Now, in addition then, when a lab reports your thyroid levels, they're usually going to report a T4 thyroid and a T3 thyroid. T4 thyroid is one form of thyroid hormone that's made by your thyroid gland. T3 is the other. Your thyroid, predominantly 90% or so of what it makes is T4. The other 10% is T3, okay? And out in the tissues, all of that is turned into T3, and it's T3 that actually makes us run, okay? That's just how we're designed. So your T4, your free T4 is in normal range. It's a little bit on the lower side, but even though it's in normal range, that might not be your normal, okay? Your normal may actually need to be a higher number, and your elevated TSH suggests to me that probably it should be up there a little higher, okay? And then in terms of the thyroid peroxidase antibody, I, off the top of my head, do not know normal ranges on that. So I'm not clear if that's an elevation or not. If the thyroid peroxidase antibody is elevated according to the normal ranges reporting on your lab form, then that means you have an autoimmune illness that's leading to some of your thyroid illness. Okay. All right. But again, I would only say that if the thyroid peroxidase antibody was elevated, and I just don't know what a normal range is off the top of my head. Okay. Anyhow, for this type of a situation, I would say, yes, you probably have thyroid illness. And I would want to do at a minimum things that will help your thyroid work better. All right. Number one, I would probably get on a supplement called ashwagandha that is considered to be the stress supplement. It helps your adrenals and thyroid work more appropriately and often can be enough to get the thyroid to work better. I usually will start at 400 milligram pill, and I'll do 2 pills in the morning and 2 pills between 1 and 2 with my patients. Okay. All right. Second thing, you want to make sure you're getting vitamin D in. You also want to be doing selenium, 200 micrograms a day. Those would be the big ones I would do. I'll show you an article here in a minute where I think I mentioned a couple other nutrients you want to do. I usually just give a good multivitamin that takes care of that for people. Okay. And those are the things I would do at a minimum. And probably I would try that first for about 2 months and then come back and recheck your thyroid stimulating hormone. If it's still elevated, then you might want to consider starting a thyroid glandular called desiccated thyroid, or known as NP thyroid. It's ground up thyroid gland. Okay. All right. And then let's see. Oh, you said you're on cholestyramine. Could this make the hypothyroidism worse? So the cholestyramine, if you're taking it at the same time as your thyroid, it would be decreasing absorption of thyroid medication. Okay, that's the only way it would make it worse. I don't see it making it worse in another way. Okay, all right. And then let's see, I'm alpha gal positive, so desiccated thyroid might be it would be difficult. So desiccated thyroid comes from mammals, right? And when you have alpha gal, what that means is a tick probably bit you at some time, and that gave you a sugar called alpha gal. And now your body is having an immune reaction against alpha gal. And alpha gal is found in mammalian meat or mammalian products that have mammalian meat in them. Okay. And so desiccated thyroid would be ground up mammalian thyroid gland. And so no, you would not want to do that. But what you could do is have a synthetic T4 or a synthetic T3 and see if you could manage it that way. Okay. All right. Let me just show you do a quick screen share here. All right, so I'm going to pull up my article on thyroid because I am blanking on one of the nutrients I want you to have. And so let's see. Oh, here we go. All right, so here's my article. It's called "It's Tricky: How to Diagnose and Manage Low Thyroid." I'm going to scroll all the way down here where I give you recommendations. Okay, so the micronutrients you want are selenium, and zinc I was forgetting about. So you want to be on 15 to 30 milligrams of zinc. You want to take enough vitamin D so that your blood levels are between 50 and 80. At a minimum, I usually recommend 2,000 international units of vitamin D. You want to be on 200 micrograms a day of selenium. And some thyroid supports have iodine in them, but you have to be careful with iodine because too much iodine can actually make your thyroid run sluggishly. So if you are going to have a thyroid support that has iodine in it, don't go over 150 micrograms a day. Okay? All right. All right, there you go. Okay, Gary, let's see here. I'm just checking battery status. We might get through the whole thing. All right, let's see here. Good luck to you, Gary. Hello, Jim. Let's see. Hi, Dr. Ross, and thanks for these great webinars. You're welcome. I have had a bit of a dip in health lately. It started shortly after I got the flu shot for the first time in my life, and I'm wondering if there's a connection. When your Lyme patients have had trouble after getting flu shots, what types of symptoms did they have? Also, how long did it usually take for the additional symptoms that the flu shot may have caused to end? And do you have any ideas as to why the flu shot sometimes causes people with Lyme to have additional symptoms? All right, great question. So the flu vaccine is the observation of myself and most Lyme literate medical doctors that when our patients that have chronic Lyme get the flu vaccine, their Lyme gets worse. Okay, it's just kind of a universal understanding that we see. I have seen it numerous times as well too. We're not clear why it happens. It probably has something to do with the immune system gets taxed dealing with the flu vaccine, which means it takes its eye off the ball in the Lyme, or it temporarily suppresses the ability to deal with Lyme. Okay. I have tended to see that the worsening is something that can last for about a month or two, but generally over that time, people will recover back up to the baseline that they were at. So it is a long temporary worsening of symptoms, basically. And other than still doing your things to lower your germ load, your herbal or prescription antibiotics, and managing excess cytokines by being on curcumin, as you know, I like that. And the curcumin being at a product by Thorne called Thorne Curcumin Vitazone is what I recommend. And it's a 500 milligram pill. And I usually have people do one pill 3 times a day. That lowers inflammation, can help your immune system start working better. So other than continuing to kill your tick-borne infections and controlling your cytokines as part of that, I don't have anything else to recommend. It's kind of a wait and see approach. Okay. Now, if you've ever read anything I've written about the flu vaccine, you know that I generally suggest not getting it. Okay. And for this reason. Okay. Now, the only people I recommend getting a flu vaccine in are people that are on immune suppressive drugs as part of cancer. Okay. Or they have an immune suppression disorder like chronic kidney disease or diabetes. And also people that are 65 years of age and older may want to consider getting a flu vaccine, even if they get a temporary dip in their Lyme symptoms, because the flu and those groups I just said, people that are diabetics, chronic kidney disease, on immune suppressive agents as part of chemotherapy, and above 65 and older can have disastrous outcomes from the flu. Okay, so that's why I recommend that. So so for those of you that are interested, I'm going to do a quick screen share here. All right, so let me come up here. I'm just going to write flu vaccine in. I'm pretty sure my article is, yeah, here we go. So it's this article, it's called Should I Get the Flu Vaccine in Lyme Disease? Okay. And basically it reviews those kind of things I was just talking with you about. All right. The other thing I would point out about the flu vaccine, and as with any vaccine that we do, it's about weighing out risk and benefits, right? So if you're in a high risk group, the risk of getting a flu vaccine and having temporary worsening of your Lyme symptoms may be outweighed by the risk of getting really bad harm from getting the flu. Okay. All right. But then there's one other thing that gets tricky in this whole thing too. And that is the flu vaccine is just not universally effective. If we look at studies that are done in the period after the flu vaccine, the year after, if we look back after the season where we used a certain flu vaccine, it seems that only any given flu vaccine is only about 40 or 50% effective anyhow. All right. So there you go. Those are other things to consider in it too. Okay. All right. Good luck to you. All right. Hello, Michael. Let's see. Dr. Ross, will you talk about early onset of Alzheimer's, probably caused by Lyme disease, and good supplements to take? Is there a way to distinguish causes Lyme, mold, other? If so, what tests are available? Either chemical test or verbal psychologic test. Okay, so it's a very interesting discussion. I was at this weekend, as I mentioned earlier, I was at a medical conference where I was at a conference called by the American Academy of Anti-Aging Medicine. And specifically, I was in a bunch of workshops dealing with hormonal management, and that's both hormone replacement therapy for women, testosterone in men. It dealt with thyroid, it dealt with cortisol, it dealt with diabetes. But part of those discussions then, as a part of that, was the discussion of Alzheimer's, all right? So because there is some interrelationships, all right? So when we're talking about dementia, of which Alzheimer's is one part, there's a number of things to consider that can impact whether somebody gets it, okay? All right. One of those is a genetic risk factor. And so if you have a genetic profile that includes something called ApoE4, there is an increased chance that you may get Alzheimer's, okay? But that doesn't mean everyone's going to get it. You have a greater chance of getting it if you have 2 ApoE4s, but having just one increases your risk, okay? All right. Then here's the other things that can influence whether we get Alzheimer's or how we do, all right? And this is a fully functional Alzheimer's dementia is a functional medicine problem, all right? So there is a physician named Bredesen that has a protocol called the Bredesen protocol that is now being invested. There was a preliminary study that he did showing good benefits from doing some of the following things I'm going to tell you about. And now there is a multi-center research study going on looking at a modified Bredesen protocol, okay? So these are the things to deal with. Number one, get sleep. 7 to 9 hours of sleep makes a big difference, okay? Number two, have good social interactions. Even if you're demented, try to do things that get you out and have you socially interacting with people, all right? Number three, being on an anti-inflammatory, predominantly plant-based diet probably is going to be best for you, okay? All right. Number five, deal with any hormonal imbalances, whether that's female hormones, male hormones, adrenals, thyroid, get those corrected, all right? Number five, I think, and I'm probably going to miss some here, this is where infections come in. You've got to remove anything that leads to chronic inflammation. One of the big ones is get diabetes taken care of, because diabetes is extremely inflammatory, okay? But the other thing about getting inflammation under control is dealing with those things that produce inflammation. So tick-borne infections, mold toxicity, other kinds of toxins that are in you, any chronic infection. You want to deal with the infections to help get them under control, okay? Those are the big components. Oh, moving, having movement, exercise can be very helpful as well too. So it is possible that instead of thinking of Alzheimer's as being one thing causes Alzheimer's, it is not a one thing causes Alzheimer's disease. Rather, it is multiple things that add together. All those factors I was just talking to you about add together to produce the illness. And you can correct many of those. So you can treat your Lyme, you can treat other infections, you can start exercising if you're not, you can eat a healthier diet, you can start doing social interactions with your community, you can balance out your thyroid, you can get your diabetes under control or pre-diabetes under control, you can get sleep. All of those factors put together can produce some good outcomes and improve the status of somebody living with Alzheimer's or prevent somebody from developing Alzheimer's, even if they have the genetic predisposition for it, okay? So let's see. Can you distinguish the causes? The answer is no, but they all add together to give it, okay? And then there is some testing available now. I believe Bredesen or somebody is coming up with a testing profile that looks at things like p-tau. There's another marker too. I need to get more familiar with it. In fact, I'm actually, because it's a very interesting area, in a month, I'm going to be in Orlando at a conference on dementia. And I am sure I'm going to be learning more about the markers that you can test for. Okay. But this framework that I told you about is basically how you approach it. Okay. All right. Good luck to you, Michael. Hello, Keisha. Hold on here a minute. I just noticed my glasses just came slide down like crazy tonight. Let's see if I can keep them on my face here a little bit better. All right. Hello. Thank you, Dr. Ross, for hosting this call tonight. You're welcome. I have a question about ATP 360. I did review your website on powering up the mitochondria. I was just curious if there was any type of lab test that would help me to navigate what patient needs to use ATP 360 versus the ATP fuel, for example. If their phosphorus is low, if their CO2 is low, how would I know? Okay, so unfortunately, we do not have, no one has designed an accurate test to tell you how your mitochondria are running. Blood test, I should say. There is a way of doing it. I think VO2 max measurements when you're exercising, it can give you a clue as to whether you have mitochondria dysfunction, but we don't have a set lab test that says mitochondria dysfunction, okay? Nor would I found any markers like phosphorus or carbon dioxide that are predictor of what's going to work or not. Okay, now let's talk about the difference between ATP 360 and ATP fuel, because there's some differences in what's in those and renders the ATP 360 more effective. Okay, that's the bottom line I want you to know. All right, so a key component of repairing injured mitochondria is to repair the membrane of the mitochondria. All right, and that membrane is made up of different kinds of phospholipids. Both ATP 360 and ATP fuel have phospholipids in them. The ATP fuel is a group of phospholipids that is called NT factor. The group that is in ATP 360 is a broader group of phospholipids that was designed by research nutritionals, versus ATP fuel is this NT factor they've purchased from somewhere else, okay? It appears the ATP 360 is broader in the group that it has, okay? Number one, okay. Number two, both ATP fuel and ATP 360 have various micronutrients like coenzyme Q10 and few others that can make your mitochondria work better. But there is one big difference between them in addition to the phospholipid mix that I think makes the ATP 360 better. And that is the ATP 360 has a component called, or a substance in it called PQQ, also known as pyroquinolene quinone. That's a mouthful, right? But what pyroquinolene quinone does is it leads to mitochondrial biogenesis. It promotes increased mass of the mitochondria and perhaps even increased mitochondria numbers, okay? So when we look at studies, I haven't seen anyone do a head-to-head study between ATP 360 and ATP fuel. My impression, though, working with both of them over the years, ATP 360 is more effective. Research Nutritionals has done studies looking at the effectiveness of ATP 360, and their studies show, in their studies, that you can see marked improvement in thinking, marked improvement in energy levels as well too. And so I find it to be quite effective. I like it better than the ATP fuel because in theory, it's doing a better replacement of the mitochondria phospholipids. In addition to the pyroquinolene quinone and its ability to increase mitochondrial mass, I think is very important as well too. Okay. All right. Good luck to you, Keisha. Actually, I'm going to do a quick screen share here. All right, let's do this together because I think I have this graph here. Oops, yeah, ATP 360. That's weird. Don't quite know why that's not coming up the way it should, but let's do it a different way. All right, so we're going to look under research nutritionals. And this is the ATP 360 product. And I believe nope, I don't have it there. I don't think I have it here. I thought I had the diagrams from Research Nutritional showing the degree of improvement, but it looks like I don't. Anyhow, I was going to try to show you their research, actually. Okay. Anyhow, what I'm really perplexed by is why ATP 360 is not showing up on my search. Makes me want to look at one more thing. Nor is the NT factor. All right, one more thing. Well, that's working. Okay. Boy. All right, let me get out of here. Okay, let's see where I am here. 8% battery. We're still going. We'll keep going until that runs out. One of the things I've done to preserve my battery too is I've got my screen, the intensity of my screen really dimmed, which makes it a little bit harder for me to read things, but I'm still able to do it here. All right, let's see. Hi, Dr. Ross. I'm wondering what your thoughts are on electrical hypersensitivity syndrome, which I developed after Lyme. So I don't have a specific thought. I just give you some general ideas. So when I see somebody that has hypersensitivities, electrical hypersensitivities, I'm thinking of an agitated nervous system, okay? And I would put that in the same ballpark as, believe it or not, is multiple chemical sensitivity as well too. There's a couple things to consider. One is when you have marked sensitivities to a variety of things, consider if there's mast cell activation syndrome there, okay? That's one thing. Secondly, when we develop these hypersensitivities, there's a part of our brain that reacts to things that don't feel right, okay? And that's a part of the brain called the limbic system. The limbic system is your fight or flight response center of the brain. It also controls things like our drive to reproduce, whether we're hungry or to eat when we're hungry, basic functions like that, okay? But if it gets overly turned on, it basically is sending out these fear signals and react signals to anything that doesn't feel quite right. And it can make it even a lot of times worse, basically, all right? So whenever I have somebody that has sensitivities to anything or multiple sensitivities, I want to explore, is there mast cell activation syndrome there? And I also want to do something called limbic system retraining. And so the programs that you can do for limbic system retraining are literally helping to reset that agitated part of the brain, okay? So there are three big programs that are out there. One is something called the Gupta program. That's Gupta. There's another one called, by Annie Hopper, called Dynamic Neuro Retraining System, also known as DNRS. And then a more recently popular one is something called Primal Trust. And all of them work with ways of becoming less reactive. Some of it involves meditation, some of it involves mindfulness. There's other exercises you can do, journaling, etc., that are just means of trying to calm things so you are not as reactive, basically, okay? And so regarding the three, they're all different. I encourage my patients to go ahead and go to the program websites, read them, and see what resonates best with you. Because the thing that resonates best is probably the one you're going to do. And secondly, it may be the one that's going to work for you too, okay? All right, so that's one thing I would look at. And then in terms of mast cell activation syndrome, things to consider with that, take a look at my article on that. And that's this article here, okay? All right. Okay, let me get out of here. Good luck to you, Leslie. Hello, Mira. Let's see. Hello. Can you treat yeast, SIBO, Lyme, Bartonella, and mold illness together, or do you recommend a specific order to treat yeast first, mold next, etc.? Thanks, as always, for these amazing webinars. All right. So generally, what I like to do in situations like this is I like to attempt to clear yeast first because there is something related to SIBO, which is SIBO stands for small intestine bacterial overgrowth, and that what is related to it is something called SIFO, F-O, and that stands for small intestine fungal overgrowth, which means you got yeast in your small intestines, all right? So the attempts you take to clear yeast out of your intestines, your large intestines, by treating yeast overgrowth there, may resolve what you think is SIBO based on symptoms, because you're getting yeast out of the small intestines, all right? But keep in mind, true SIBO means intestinal bacteria overgrowth. And the way to diagnose that is a breath test. And on the breath test, you drink a sugar and then you breathe into these tubes. And if you're fermenting sugar, you're going to produce hydrogen or methane gas. The test measures whether you're doing that. And if you are producing those, then that requires separate treatment from treating fungus, okay? But in a situation, I would go yeast first, because if you can clear that, you may resolve some of those symptoms you think are SIBO, okay? But if you don't, and if you've blown methane and you've blown hydrogen, then I would deal with your SIBO next, okay? The reason I would do the SIBO next before moving into a Lyme, Bartonella, mold is it's hard to take a bunch of stuff when your gut is ballooning up all the time from too much gas, okay? So I usually find that you just got to clear yeast first in this situation, get the SIBO out next if you're still very symptomatic after you get rid of yeast, and then move into your mold and your Lyme and your Bartonella treatments, okay? That's usually how I would do a situation like this, all right? All right. Good luck to you, and thanks for the question. Hello, Joe. Let's see. Hi, Dr. Ross. Can you tell me if there are any cardiac effects from taking Atovaquone, and what would be the most common side effect? You know, what I see with using Atovaquone is more GI, like nausea kind of side effects. I have not seen cardiac with it, but bear with me. I'm just going to pull up my side effect manual here. I guess what I would say is generally I'm finding it to be pretty well tolerated for the most part. Okay, so I just want you to know that. All right, so adverse reactions. Headache, back pain, dizziness, some nausea, as I said, diarrhea. Those tend to be more the things I see as the nausea and diarrhea. Some liver inflammation, some insomnia, some sleep disorders, anxiety, photophobia. You asked about, common. So the most common I find, and they don't even list anything cardiac in here at all. And I haven't seen any cardiac issues at all either. Okay. So to answer that part of your question. All right. All right. There you go. Good luck to you, Joe. Oh, the one thing you need to do too, before you take an Atovaquone, which is Tafenoquine, everyone, is you want to check a G6PD level. And that is to make sure, because if you don't, you may develop hemolysis. Okay. All right. That would be one thing that can happen. Okay. All right. Good luck. Hello, Teresa. Let's see. Hi, Dr. Ross. I've heard you state that ongoing testing for tick-borne diseases after diagnosis is not useful. Why do so many LMDs constantly test? I recently acquiesced testing with Galaxy, everything negative. I've tested positive for the 3Bs in the past. Symptoms seem ongoing despite various treatments. Was I silly as I'm accusing myself of paying a high cost for basically nothing? Okay, so I think there's a genetic profile of doctors that we think that testing tells us everything, and it doesn't. And my colleagues, we're all taught in medical school to like rely on the test, and don't trust your clinical thinking. Just rely on a test. That's kind of what we are programmed to do. And I'm jokingly saying, I wonder if there's a genetic predisposition that leads us to do it too. Okay, all right. So just get that out of the way. I don't agree with my colleagues, and here's why. So a negative test in these disorders can occur for a few reasons. It could occur because the immune system isn't fighting the infection anymore because it's gone. Okay, that's one reason. Okay, and that's why a lot of my colleagues retest. They're like, oh, well, if there's not an immune reaction, or if it's less of an immune reaction, it must mean the germ is gone. Well, who knows? Okay, all right. The problem with it, though, is these infections don't always trigger an immune reaction. Especially if the germ is very active, it may be releasing chemicals that make it so the immune system can't make antibodies. So your immunoblots or Western blots or IFA test will be negative, even though the germ is partying on, okay? Or the chemicals they're releasing make it so your T cells that attack germs can't fight them well enough. So your T cell reaction test, which is called an ELISpot, will be negative, even though the germ is partying on, okay? And then the other situation is direct testing, where you can see it under the microscope, like doing a TLab test or doing a FISH test or doing a PCR blood test. Those tests are not that sensitive. They often will miss germs because when you stick a needle in a person's arm and you draw the blood, it just may not be in that sample. So having a negative test does not exclude the infection if you're using one of these direct tests, okay? So in my experience, I've never found them to be reliable. I treat based on symptoms. And I'm always considering, could there be something else causing those symptoms? But I have found the best benefits by putting my hat on and thinking clinically, what does this look like? And if the clinical says it's still probably active, I keep treating, okay? Now, I must admit, I may be an odd duck. When I first got done with my family medicine training at Georgetown University in Washington, D.C., my first job was taking care of homeless people on the streets of Washington, D.C. So I couldn't rely on testing. I had to use my clinical judgment. So my skills at thinking through clinically what could be going on was refined at that part in my professional career. And I still tend to rely more on that. Most doctors, though, I think, unfortunately, are brainwashed into thinking it's the test that gives you all the information. And it just doesn't. Especially when the testing is imperfect, it just doesn't. Okay? All right. Good luck to you, Teresa. Oh, where are we here? Hold on here a minute, everyone. %. We still got time, it looks like. All right, for those of you who don't know what I'm talking about 6%, as I said earlier tonight, I forgot to bring my charger home for my computer, so we're operating on a battery that is very low, which is interesting. We're getting about an hour out of this webinar. We'll see with 6% battery charge where we can go the whole hour and a half. I'm kind of doubtful about that, but we'll keep going, okay? All right, hi, Leslie. Let's see. I don't know if my question went through. I'm wondering about your thoughts on, oh, it did. We answered that earlier. All right, so Angie's got a question. It looks like it's in two parts. Part one, can someone get better treating 3? And then there's a second part I found here that says, Didn't get a chance to finish my question, but meant to ask, have you seen patients get better microdosing, like 1/4 drop crypto daily? So yes, maybe not quite that microdosing, but small dosing, yes. So there's a group, especially in really sensitive people, that again, the sensitivities may be due to mast cell activation, maybe due to limbic system that needs to be retrained. I mean, I would deal with those, okay? But there are some people that I have found that are just going to stay reactive. And I think there's a third reason that reactivity can occur, which is some people just have impaired detox. And so therefore, when you think about how a drug kills germs, you have to build up an adequate amount in the blood to get killing, all right? And what determines your blood levels is how much do you take and how quickly does it get detoxed out, all right? So if you're somebody with a lot of sensitivities and you have impaired detoxing ability, that means you don't need to put as much in to get adequate blood levels. And so I have gotten people well, for instance, on a person I was treating from Canada at one time years ago, that the best we could do with, at that time I was using cat's claw and Octoba for Lyme, Hutania pseudocuta for Bartonella, and I was recommending up to 30 drops twice a day on all of those. I think we got her well by doing 2 drops twice a day of everything, basically, right? So it is possible to get better on microdosing. And again, I think the reason is that in some people, it's because they just can't clean it out fast enough. So you don't need as much to maintain an adequate killing drug level. Okay? All right. Thanks for the question. Hello, Keisha. Are you set up to see person from any state via educational visit? Yes. So the educational consult visits that I showed you earlier, I can do for anyone in the United States, in Canada, around the world, because I'm not officially diagnosed. I don't write a diagnosis code down, and I don't prescribe, and I don't order tests. It's an educational visit. Now, if I do wind up prescribing, or if you want me to prescribe and you want me to do a formal diagnosis, and you want me to order tests, then we need to set that up as a full service visit where you come to see me in person the first time. And if you're not a Washington State resident, subsequent visits have to be in person. Washington State residents, though, because I'm licensed here, I can do telemedicine from them wherever they are, and we can do video visits after that first visit. Okay? All right. All right. Good luck to you, Keisha. And so for those of you that want to know, I only started seeing people clinically a month ago, so I still have space, right? But I'm sure that's going to fill up fast. So if you want my input, this is the time to do it. It's fairly easy to get in to see me right now. Okay? All right. All right. Hello, Lee. Let's see. Sorry about the bold font. Oh, it's not showing up as bold font on my side, so that's good. I was excited when you said last week you participated in Hormones Conference. Looking forward to your sharing your ahas, especially as possibility, probably definitely connected with mold, Lyme, tick-borne infections. I don't have specific things that are Lyme, mold, or tick-borne infection related, other than I'm more interested now coming out of this workshop on the inflammatory nature of adrenal stress. If your adrenals get stressed because you worry a lot, or you're overworking, or there's too much disease burden on you, that can be inflammatory and make it harder for your immune system to work. It can lead to weight gain. It can lead to immune dysfunction. It can lead to bone thinning. It can lead to even thyroid thyroid disorder. It can lead to diabetes. Actually, you get decreased insulin sensitivity. Anyhow, it just becomes a huge mess, right? So I've always focused on adrenals, but I think I'm going to be more aggressive now about doing adrenal testing, either as a urine test, like a Dutch test, or saliva testing to find out what's happening with cortisol levels during the daytime, and probably being a lot more aggressive about that as an aspect. And especially if people are having a lot of stress, giving them the tools, promoting the tools like a Gupta method or an anti-hopper like I talked about earlier, or a primal trust, so that they can learn to deal with that stress, advising, changing jobs if they need to, whatever. I'm going to be a lot stronger about doing that because that can be tough. Okay. The second thing is the role of diabetes in all this. There is such a epidemic now of people that have pre-diabetes and diabetes, and some of that having chronic inflammation from infection can lead to diabetes or pre-diabetes, because the inflammatory chemicals make it so you have decreased insulin sensitivity and you can develop diabetes. But diabetes itself is inflammatory too, because all the fat you develop, et cetera, is inflammatory, right? So I'm going to be starting to test a little bit more. I'm going to be looking a little bit more aggressively at sugar levels and hemoglobin A1C in my practice that I wasn't doing before, okay? And then in women that are not on menopause treatment, because we weren't supposed to do that. We were told by the authorities to be, don't do that, you're going to harm them. Well, that was all wrong, especially in women that are 65 years of age and younger that have menopausal symptoms. I'm going to be a lot more forthright about starting hormone replacement therapy for them, because that can help the immune system work better as well too. In men, older men, I'm probably going to be a little more aggressive about testing testosterone levels, because if that is edging towards the lower side, that can sometimes result in immune dysfunction as well too. So those are some of my big take homes from that, okay? The other take home I would say is infection, inflammation can lead to dysfunction of your testosterone, your female hormone systems, your adrenals, your thyroid, even diabetes. There's an interplay that goes both ways here. Okay. All right. Thanks, Lee. Oh, one of the more interesting things I should tell you too is, we officially say somebody has diabetes if they test a couple times for a fasting blood sugar above 100. But there's data that is showing that if you get a fasting blood sugar above 84, your risk of developing full-on diabetes by official standards, meaning 100 or more, it goes up by 6% for each 1 point you're above 84. So for instance, if you have fasting blood sugars at 90, which is 6 points above 84, and each of those carries a 6% increase, that means you have a 36% chance of developing diabetes. All right. So I'm going to start being a lot more aggressive on trying to get people moving, going to plant-based diets, to improve the possibility of not developing fulminant diabetes, maybe even going to the GLP-1s earlier than I might have before, because diabetes itself is just such a horrible condition in terms of immune suppression and damage to the body as well too. So that was one of the other big take homes I had out of this as well too. Okay. All right. Hello, Gal. Let's see. I'm being treated for Bartonella and Anaplasma. I'm being treated with Burbur, Panella, and Houtenea, Cryptolepis, orthomolecular tincture with alcohol, and Japanese Knotweed, transresveratrol extra, in addition to curcumin and AC quercetin. If I were to follow your 3-item recommendation for Bartonella, which additionally includes the oregano, cinnamon, clove, do you think I would need to continue the Burbur and Houtenea? No, I don't. So the Burbur is being used in that combination because somebody thinks it detoxes the brain, all right? And the reason I say somebody, it comes out of the Cowden protocol. There's no science that supports it. There's no science that says Burbur detoxes the brain, okay? What does detox the brain and detox every tissue in the body is glutathione. So if I have detox concerns in my practice, I like using glutathione. I like using a liposomal variety of glutathione because that increases the absorption. And the product I like for that is a product by Research Nutritionals called Tri-Fortify, okay? That's what I like to do there, all right? But yeah, so anyhow, I just want you to know that, okay? And the Tri-Fortify would do 1 teaspoon a day. But in terms of a germ killer, no, Burbur's not doing anything there. And Houttania, I used to use it in my practice, but I really do find better results with a cinnamon clove oregano, a crypto, and a Japanese knotweed. I just find better results with that. So you could get rid of the Houttania, okay? All right. Good luck to you, Gail. Let's see here. Hello, Lee. What do you think about a thyroid or lung nodule connected with caused by bugs such as the 3Bs or other parasites? What I would say is maybe they could be, but there isn't any science that says they are. We just don't have it. We do have, there's some limited science that shows, oh God, I'm blanking on his name. I could even see his face. There was a Lyme doctor that was a cancer researcher out in North Carolina, I believe North Carolina. Oh, what is his name? He eventually died of Lyme, unfortunately. He got Lyme, got heart failure, had to have a heart replacement. And anyhow, his body of work was looking at cancer and Lyme. And there was some relationships. I think he was finding some relationships, I believe, with breast cancer. Don't hold me to that, okay? But he found, at least laboratory-wise, some loose relationships. So maybe there's some cancer risk, but I would tell you, it is just not, it's not a solid link at this point, okay? All right. Thanks, Lee. Hello, Gail. Let's see. Forgot to add that I'm also on biocide and a biofilm destroyer. Gail, I'm not sure how that fits in with the rest of your question. I'm not remembering what your original question was, unfortunately. Hello, Cami. See, I have Lyme, Bartonella babesia, Miyamoti strain as well. What do I start treating first, or is there an herb that treats all of these? I can't take antibiotics from giving me C. difficile. So if you want to treat all 3 germs, Lyme, Bartonella babesia, the herbal combination that will do that is to use a combination of Cryptolepis, Japanese knotweed, and a pill that is made up of liposomal cinnamon, clove, oregano, okay? And the dosing I usually would do for this kind of a situation, the babesia requires a slightly higher level of the Cryptolepis. So I try to start at about half a teaspoon 3 times a day on the Cryptolepis. And then for babesia, I like to move it up to a teaspoon 3 times a day. Cryptolepis is one of the strongest herbs we have for babesia. And in addition, about 4 or 5 years ago now, Johns Hopkins University was able to show in the lab that it's quite effective against growing and persister Bartonella and growing and persister Borrelia. If you're new to this, persisters means that some of the germs go into hibernation. And those hibernating germs, we have a hard time killing, all right? And some of the things that seem to do the best at killing the hibernators are these herbs, okay? So Cryptolepis, all right? Japanese knotweed has lab evidence that it's going to kill growing and persister Bart, growing and persister Lyme, has weak activity against babesia. And the cinnamon, clove, oregano oils are great at growing and persister Bart, growing and persister Lyme. And the clove in there has some activity against babesia as well too, okay? That's what the laboratory tells us, okay? The cinnamon, clove, oregano, in addition, can help remove a slime layer that covers these 3 germs called a biofilm. It helps break that down. The product I like for cinnamon, clove, oregano is called liposomal Cinnamon Clove Oregano Essentials by a company called Dr. Inspired Formulations. For my Cryptolepis and Japanese Knotweed, I like products made by Montana Pharmacy. I'm going to do a quick screen share here for you. Oh, the other thing, so in general, herbal antibiotics tend not to have the risk of causing a C. difficile overgrowth. Okay, I just want you to know, in general, okay, that doesn't mean it's zero. Okay, so the other thing that I would do if somebody has had problems with developing C. difficile overgrowth in their intestines is to be on a probiotic which is called Saccharomyces boulardii, also known as Saccaro B. It's a healthy fungus that does a good job of preventing and even treating, or I can't use the word treat, but managing C. difficile, okay? So, and that would be to take that as a preventive, 2 pills 1 time a day, all right? That's where I would go, actually. Now, let me do a screen share here. Okay, so for the cinnamon clove, wow. I gotta tell you, I am really upset with my search tool on this site. It's just not showing the stuff. It's like all of a sudden, I trained it last week to see things and now it's not seeing it at all. All right, so let me show you how you find the, so Dr. Inspired Formulations makes this product called liposomal cinnamon clove oregano essentials, okay? That's the product you would want there. In terms of the Cryptolepis, oh my gosh, it forgot all of my Cryptolepis too. All right, so in terms of the Cryptolepis, you want to go over here to Montana Pharmacy. Wow, why is that not doing this? There we go. Montana Pharmacy. And your the Cryptolepis is here, okay? And then the Japanese Knotweed is right there, okay? And I just got to see one more thing here. Oh boy, this thing is just not working. I'm so frustrated. I'm so sorry, everyone, that my site is so dysfunctional. I'm very frustrated with it too. This is a site I had rebuilt this summer, and it's just been difficult ever since I did that, okay? Anyhow, there you go. So Gail says power plate and red light therapy are game changers for neuropathy. Okay. And they may be helpful for some people. So I can't refute that. Okay. All right. Let's see here. Let's see how much battery I got left. Well, I don't know how it's hanging on, but it is. All right. Let's see. Nancy says, I saw a YouTube video by Dave Asprey as the superhuman, and he interviewed a gentleman that makes EWAT machines. This is exercise with oxygen therapy for healing Lyme and Bartonella. It is about $2,000. Not sure you have heard of this. I did IGeneX test and positive for Bartonella and Lyme. I do the Ebon Charge infrared blanket for 30 minutes sometimes. I don't feel aching, but only lasts a couple hours. Also, I'm taking Bactrim diflucan when I have vaginal yeast. I'm not seeing much difference. I wake up during the night with burning hands and feet. I also take curcumin with pepper, viticidal, liposomal glutathione, SMP active by Metagenics. I also use vibration machine by PowerPlate to strengthen bones and stimulate muscles. What combination, in your opinion, would I tell doc to add? He says if nothing happens in 3 months to consider SOT or R strain, but it's expensive and no guarantee that it'll work for only 1 session. All right, Nancy, that's a lot of stuff going on there. And I guess what I would say is I need to ask you a lot of questions. And so you might consider, if you want to get my input on this, consider doing one of my consults. Okay, one of my educational medical consults. I'd be glad to look at that with you. Okay, all right. Good luck to you, Nancy. Oh, in general, as many of you know, I don't believe in SOT therapy. SOT, we have no science that actually says it does anything. And there's many reasons to believe it should not work. It's very expensive. There's a lot of doctors making good money on it, but I have yet to see anyone that has had sustained results from it. Okay. All right. So, and you'll hear people that say they get benefit, but I think a lot of that may be healing effect, or what we call a placebo effect, but I don't think it's sustained. Okay. So if you want to see some more information about why I don't support the idea of spending thousands of dollars on SOT therapy, take a look at my article. It's this one called, "Is SOT for Lyme and Tick-Borne Infections a Scam?" And I think it is. All right. Okay. All right, Nancy. Good luck to you. Hello, Nancy. Is the FY Dr. William Davis, his YouTube video on SIBO. He also gives more information in his book, Super Gut, and how to make 2 different yogurts, L. reuteri, L. gasseri for SIBO. He also has a SIBO tester that is reasonably priced. Thanks for letting us know. Hello, Brenda. Let's see. What herb can you take in place of Japanese knotweed? Depends on what you're trying to treat. If you're trying to, as you know, in my protocol, I recommend the cryptolepis and Japanese knotweed and liposomal cinnamon clove oregano. Okay. If you have Bartonella and you want to remove the Japanese knotweed, I might consider taking, going with a Houttenia, 30 drops twice a day. Okay. If you have Borrelia and you want to remove the Japanese knotweed, I might consider putting in cat's claw. If you have both Bartonella and you have Borrelia and you want to remove the Japanese knotweed, then I would go ahead and do cat's claw, and I would do the Houttenia. Okay? All right. Good luck to you, Brenda. All right. All right, everyone. Believe it or not, that is all the questions I have here. And I literally have, I think, 1%. Yeah, I do have 1% battery. So I'm going to wrap up before it goes totally dead and I don't get to say this. I want to wish everyone happy holidays, all right? And I hope to see you all back here again in the first webinar I have in January, which will be the second Thursday, because the first Thursday is January 1st. And for all of you, Happy New Year's as well, too, okay? And then I will, let's see, look tomorrow morning, somewhere around 10 a.m. Pacific Standard Time, I should be able to get the recording out to you.